our last day of substance of content for this course. The first half, I'll be talking about the readings that I've assigned, and after our break, we'll hear from three of you about your own work. So the previous class was meant to show, well, the first two readings are meant to show work that is in favor of the movement for global mental health, in the broad sense. Well, I think, and for some people, it's not that you're for or against, it's sort of more nuanced. How do you do it? And the China Mills work is obviously critical, and this volume is obviously critical because the subtitle is Critical Views from South and Southeast Asia. So I should tell you a little bit about how this project came to be, because I think it's actually good for many of you who are working on PhDs to learn how projects come about in the academic world, if you're thinking of going into academia. So I was invited to join a conference, or almost like a workshop. It wasn't like a big disciplinary conference. It was just a group of people invited, led by William Sachs, who's at the University of Heidelberg. He was able to get a large grant from the German government to study, bless you, alternative views and mental health, to also examine the movement for global mental health, a variety. I actually forget exactly how he defined his grant, but okay, bless you all, yeah. But the grant provided money to bring a large group of us together in Istanbul one summer, and about half of the people in the group were from India and half were from Europe, and Istanbul was meant to be a place that wasn't going to be too hard to get, and a place that Professor Sachs thought would be a nice, relatively warm place in the middle of the winter when we were meeting in December. And then the following summer, there was a second meeting of almost the same group. Not everybody could come who came the first time, in Malta, a little island nation in the Mediterranean Sea. Really interesting and unusual place to visit for many of us. Part of the academic research projects like this allow you to visit really interesting locations. And this project was also a joint venture, as it were, between the University of Heidelberg, also Edinburgh University in the UK, and JNU in Delhi, and the Achyuta Menon Center, where Dr. Ravi Varma works, in Trivandrum. And people from those organizations and other places, had come to the conference, and we all shared papers that critically engaged with the movement for global mental health, twice. And then we went forward and we discussed, what do we do with this? What should be our product of these meetings and of this grant? And this is the normal product, an edited volume. So we decided to go forth with an edited volume and contribute. Not everybody stayed in the project. If you ever have an academic job and try to do an edited volume, it can be quite difficult to get people to commit and follow through on their articles. I tried it once and it didn't work. It just couldn't get people to commit. But I think because we met in person 2 summers in a row and got to know each other well and felt committed to the project, everyone came through, and we produced this volume that critically engages the movement for global mental health. And so I know I mentioned that the readings for today, I'm not weighing as much on them. I'm not considering them as important, and I know some of you may just be working on reviewing the other readings. But for those who may have read these two pieces, I mean, one of them, I mean, the first one I assigned is, I mean, it's this one. It's called just Global Mental Health, but it is the introduction to the volume. It's just not called Introduction. And they outline the various critiques that are included in the volume. They preview the various articles. Can anybody identify what were some of the primary critiques that are offered by this volume? Yeah, why don't we go with Rini?
So basically, in this article, as far as I understood, it talks about the author basically critiques that it's not the psychiatric or the medicines or the drugs that might help people to overcome the psychiatric problems, but then also like the culture plays a very important role, so to say, as in like it's not that the traditional healings might not be effective as such, but then it says that traditional, instead of eradicating traditional healings, we might think of acknowledging them and make use of it so that like people in the local areas can also be benefited. So this is one of the critics they say. And yeah, overall I thought about this thing, read about this thing, and then also it talks about the treatment difference and treatment gap. That it's not just the basically there are a lot of treatment differences that every culture might have. So this thing they talks about it. Just like they give this example of farmer suicide in India, and then they also said this particular problem of any psychiatric issues or like suicide might be because of the political issues and not necessarily because of somebody is going through depression or something like that. So I think these three were the major points that were in my mind.
Okay, very good coverage of the major points. Yeah, and the sort of the issue with traditional medicine is very central to many of the points they bring up. Other things that weren't on her list?
About the diagnosis and identification of mental disorder in itself, like who decides what mental disorder is, why, and I really liked how they say the disease entities in clinical psychiatry is Bible. Like, that's how they say DSM, and I think
DSM,
that
yeah.
is very Euro-focused, and it doesn't really consider the traditional or indigenous categorization, or if something is categorized as a mental disorder in DSM or ICD, it is supposed to be considered a disorder worldwide, but it might not be so. Something that is considered a disorder for the mainstream dominant discourses might not be a disorder in the other indigenous Western, non-Western societies.
Okay, cultural variability in mental disorders too.
I
Yeah,
think we saw that in the previous readings when we talked about Siemens laws and.
Oh yeah, right. Yeah, exactly. Right. Yeah, there's that too. Yeah. Okay, very good. Let me just go to. I highlighted one of the ways that they kind of sum up what they call the problematic assumptions of the, and also I highlighted that other line. We applaud the MGMH's willingness to engage in self-criticism. Okay, so they acknowledge the willingness to engage, self-criticism, but also with outside critics as well. But the following problematic assumptions they list is for the idea that mental disorders can clearly be identified, that they are primarily of biological origin, that the world is currently facing an epidemic of mental disorders, that the most appropriate treatments for them normally involve psychopharmaceutical drugs, and that local or indigenous therapies are of little interest or importance. So that's several assumptions that they're going to explore in depth. I think the first one, the idea that mental disorders can be clearly identified, I don't think that was a necessary target, of critique. I think that in the introduction, they actually spend too much time trying to critique mainstream psychiatry, and how its inconsistencies, and I think that's sort of too big a topic to take on. I think they could have just briefly referred to controversies within psychiatry about the biomedical model to actually kind of claim that mental disorders are hard to, sure, and yet people in psychiatry have argued, based on the WHO studies that I've mentioned before, that among the other various things they show, having to do with outcome, they also seem to show that, they claim to show that, you can identify something called schizophrenia in different parts of the world. Now critics say, well, is it really the same thing? Can you, is it, that still might be a tenuous identification. But I think I would agree that, there may be something you call schizophrenia in biomedical psychiatry. These problems may go by other names, similar problems, maybe they're the same, but it really does seem that in many parts of the world, people identify certain people as crazy. Because I'm using that folk term because that's often the term, some kind of local language term. All languages seem to have that, but where the borders are in that definition, whether they're the same as schizophrenia, I'm not sure. But someone who is having strange fantasies that people don't understand is, there's some universality. I believe. I'm not going to say everything is completely relative. There are things like amok, which is famous as like a culturally defined mental illness or sorry? Culture-bound syndrome, right? Yes, thank you. Yeah, culture-bound syndrome was a term for a syndrome, an illness that is within a culture. It's not a popular term anymore, but amok was a term in Indonesian. I believe it was in Indonesia is where it came from. But referred to this, sort of a violent, aggressive, or even homicidal period running around. Running amok in English became an expression borrowed from that. And it was a situation where somebody would have this kind of crazy moment where they would literally sort of be, I guess, what psychiatry might call a manic period, where they would literally run about and do crazy things and break things, and then it would pass, and there would be no second thing. It wouldn't be part of a long continuing thing. It would be like an isolated, one-off thing, experience. Odd case of behavior. Odd, but there was a word for it. It was recognizable as something that people did. There have been some other culture-bound syndromes. Some people have suggested that eating disorders are culture-bound syndromes. But increasingly they're something we find in many parts of the world. But once the factors that lead to eating disorders are present, which are basically, consumer culture, middle class affluence seem to correspond to that. There's an issue with identifying mental disorders clearly and across the globe, and I think that, well, at least to me, that's not the main issue here. Oh, the biological origin? Yes. Right.
It is at least partly true. So why are they contesting that? Because we don't know exactly the etiology, but there is definitely biological.
Well, I also think that that is probably not a good argument to take on in the introduction to, although I was part of this project, I think we all gave some feedback in the introduction. There were certain things that Sachs and Long wanted to take on, especially Sachs. And, not all of us thought that those were battles to fight in the introduction. I mean, personally, I think there's a lot of ambiguity about the biological role, but I think they're trying to point out that the assumption of that being the essence, the main thing, is what they're critiquing. But I still think you can make the important critiques without bringing up those issues. Anyway, they've chosen to do that. I mean, here I've highlighted where they've claimed that the relation between neurochemical processes in the brain and psychiatric symptoms and treatment remain an unsolved puzzle, and that is why the pharmaceutical industry has largely abandoned research in psychiatry, resulting in a dearth of new psychopharmaceuticals. So, and this is citing Dumit, who is an anthropologist who studies pharmaceuticals. So, I imagine there are psychiatrists who would not agree with that claim. And I'm not sure about the drug industry. I have heard claims that they're working less on new psychopharmaceuticals because the interest in sort of the hard biomedical model in psychiatry has been declining. I mean, but the people I'm hearing from are the usual critics, but more from even the movement for global mental health. Let me just mention, just on the next page actually. Here it must be acknowledged that leading voices in the MG-MH have acknowledged these criticisms, some of the things they've listed above, and claim to favor a more holistic, multidisciplinary approach to mental health than previous ones. In other words, the claim is that people in the movement for global mental health are less sanguine about the biological center of the whole project, that they are embracing, a more holistic view. I mean, these things are controversial. I mean, a few years back, the president of the American Psychiatric Association quit, and in his quit, he, in sort of a protest statement, he said that the biopsychosocial model has become bio. Okay, and that's why he's leaving. So I mean, so that's a critic from within the mainstream of psychiatry. So there is, I'll just say, disagreement within mainstream psychiatry about the role of the biological, and they're taking on that issue. I think that's sort of, again, too much to take on in this introduction, but that's what they've decided to do. I mean, it is a good point when people in the West are becoming intrigued by and compelled by alternative treatments. That I showed you the New York Times article that profiled one of those leaders of the Hearing Voices movement. I remember another recent New York Times profile of Americans going to South America. Many of them have PTSD and served in the military and find that they're not able to make any progress in their PTSD, and so they're going to South America to sit with shamans, and try to find some relief, which includes using psychedelic drugs like ayahuasca. Yeah, that's become, and so to me there's this interesting contrast that while in the West, people sort of freely explore these alternatives, the movement for global mental health says, well, everybody else must take the mainstream, there's, Ayurveda does not use hallucinogens. Sorry, Peru, yeah, right, and Ecuador. Yeah, there's some concoction that they make, people go actually for all kinds of, There's a ceremony, yeah. It's done in a ceremonial manner. It's actually sort of traditional ceremonial, spiritual shamanism is done, in a way, we can't exactly say the traditional way because it's done for medical tourists. I mean, people who are coming for health problems from other countries. So it's sort of tourism meets traditional shamanism and healthcare. And people claim to have, had benefits from this. I know someone whose wife, with advanced breast cancer went from the US down to South America, well, where she's originally from, and did ayahuasca, and spiritual healing for her breast cancer. So it's not just mental health issues. And anyway, but there's this sort of a double standard in a way in this thinking that, some people should be free to explore alternatives. And here is a place, India, full of alternatives. Some may be, charlatans, but there's also long-term tried and true systems of systems of philosophy even, that part of the goal is psychological stability. I would say that's true of some of the classic Indian systems of philosophy, like Shankara is Advaita Vedanta. It's philosophy, but it's also a kind of psychotherapy, and some psychotherapists I know in India have tapped into things like that, which I think is a good idea, Anyway, and so that gets back to the traditional healing issue, which has already been mentioned. And one of the critiques of I think you also mentioned the treatment gap issue, which they critique, which I have my own additional critiques. I've noticed in the literature on the movement for global mental health, they often cite the treatment gap. The treatment gap actually in the article you guys had from Patel was identified as 70%, but most of the literature mentions a 90% treatment gap. And most of the time, they do not cite any source for that 90% treatment gap. I think it has become kind of like a folk knowledge within the scientific community that there's a 90% treatment gap. And I'm not aware of the original source, who counted this. I've never been able to trace it back. But, yeah.
In an anthropologist conference in Berlin in 2009, they showed nice video clips from city of Kolkata, where the crowded medical stores, chemist shops, and they said there are 30 brands of fluoxetine.
Yeah.
And people can get it without prescription. So there is no treatment gap in India.
And that's true, actually. So I mean, there's right.
So, and anthropologists are the real critics. They fantastically they observe from distance and nice perspective.
Right, and the treatment gap. I mean, there's the MH gap program, which comes from the World Health Organization, identifying the treatment gap and claiming, and they, I forget the number that they give, but they identify a treatment gap simply by estimating the global incidence of psychopathology, and then sort of counting the sort of number of psychiatrists and psychologists, from official records. So it's just kind of like, for the, officially registered, knowable through records numbers. They came up with some number. And, but that kind of knowledge isn't, well, that's where ethnography comes in, right? If you're on the ground observing actual behavior and you realize there's 30 types of fluoxetine, in a typical pharmacy, and probably 20, in a pharmacy in Trivandrum, except you do need a prescription in Kerala. Is that correct? It's not so easy to get medicine without a prescription in Kerala. Then we find a different reality. Whether that's closing the gap, whether self-prescription is closing the gap is a question mark. Maybe not. Maybe it's just, useless abuse of fluoxetine. But also what we do know that is not counted in the attempts to identify a treatment gap are are non-biomedical systems of healing. Okay, we know that they're only counting allopathic psychiatry and the Western sciences, psychologists, clinical psychologists, and others. So that's a clear problem. If the treatment gap idea, whatever the number might actually be of actual lack of allopathic care, what about when you include other forms of care? Ayurveda, homeopathy, Siddha, and some of these are less well known, but some of them are studied, and religious care. Psychologists at NIMHANS had done some study of religious healings. They've assessed people who, before going into these particular temples that are known as places of healing for mental problems, mental spiritual problems, and they've assessed them afterwards, and they've done some publications, and they've shown that the outcomes are about the same as going to a psychologist and taking an antidepressant. There's good evidence that people get benefits from spiritual therapies. I found that in my own work. I tried to compare in the original work I did in the 1990s with Biju, how people did upon 6 to 9 month follow-up interviews in allopathy, Ayurveda, and religious healing. What I found is that they were roughly the same. I mean, but it wasn't enough numbers to be statistically significant. I can't claim to have proven anything, but among the numbers that I did see, there wasn't any therapy that seemed to correspond to better outcomes. And so there is an evidence base for non-biomedical therapies and interventions. And they're making a similar point here. They're referring to local resources for mental health. The problem is that such resources are rarely seen by advocates of global mental health, and when they are either dismissed or, even worse, denigrated as inhumane because they do not correspond to Western psychiatric models. And again, you have the alleged claims of abuse, occurring in those systems. And this is also a good point that I'm highlighting here. So activists in the MGMH often claim that their movement is not about exporting Western therapies, but rather involves providing packages of care developed in the countries of the Global South in a situation of scarcity of professional psychiatric and psychological services, which is a sensible rationale. That's also one of the angles that the MGMH developed. It's not, sort of just about reproducing the Western model, especially in a system of scarcity. We're coming up with our own models and we're testing them out. But then the critique is the other half of this highlighted section, but these packages always place the psychiatrist at the apex of the system, and none of them include the most prominent practices and forms of treatment in such countries, namely traditional medicine, ritual, and religious healing. And one of the outcomes also of the ways in which traditional and religious healing are incorporated, and I think I've mentioned this critique already, is that they often become something like a referral service, to psychiatry. And there's also this Dawa or Dua program, maybe some of you have heard of, sort of medicine and spirituality program that involves placing mental health professionals at these dargahs and other temples. The idea is that, I think there's two ideas there, that they're complementary. But I know from some people who have done research at these sites, the goal of the psychiatrists in some places is simply to divert people from the temple into the psychiatric building that's sometimes right next to it. There's places like the Zabalaji temple in Rajasthan that's quite popular as a healing site, and some medical anthropologists have done research there, and they've added a psychiatrist, building, nearby as well. So that's sort of one of the. I'm not sure if those programs are directly, the result of the Movement for Global Mental Health. I believe they are, because we don't see the inner workings of health policy in the government. I know the Indian central government, in different parties, whether it was Congress-led or BJP, have both sort of assumed that, the WHO GAP program and the Movement for Global Mental Health just represent proper development, and it's something that they should adopt. And putting a psychiatrist near the temple is the right move. Though I wonder actually whether BJP ideologies actually might have a different view of that, and I'm not sure. I don't know. So this, and one individual, this Dr. Sood, who is cited in here, actually, let me just jump to the references. I think it's Anuba Sood. Yeah, there she is. Oh, she studied the Balaji temple. Yeah, well, you see Sood there. And she claims that the Dawa Arundua efforts have actually reduced attendance at this temple. And she suggests ways in which that might be problematic. Well, actually, let me just move on to my own article, since I know more about that one. So in this piece, it kind of is meant to go along with the article on work and recovery. In fact, some of the informants are the same people, you may have noticed, for the qualitative part. So for, what do they call her, Sri Devi, she attributes work as a factor in her recovery, but in this piece, she's also suggesting it was the support of her husband turning his support toward her and resolving family problems, and that her family situation at present when we met her was very good, very positive, and I think both things are a factor, for her, and she was, as we've said before, doing very well, seemed to be absolutely normal in her demeanor. And I've thought of trying to put all of the various things that I've done on recovery from schizophrenia, like these two articles, together with another article I've written that relates to that, and a paper I haven't published, and some grand thing. I don't know what I'm going to do with that. Maybe I'll never do that as a publication. I mean, it could be a book, but I'm going to give that as a lecture. I've been invited to give a couple talks in Trivandrum and Hyderabad and Bhopal, and I'm going to try to assemble all of the different explanations I've come up with as to the explaining better outcomes in India from schizophrenia. But you see pieces of that here and in the work article. Oh, let me move to my, I first presented this talk in Istanbul with the same title. I remember Professor Mohan Rao, who is I think a brilliant public health expert from JNU, now retired. First thing he said in response was, "My title sounds like a novel by Gabriel Garcia Marquez, who's magical realist novelist, some of you may know from South America, and I just thought, well, and that's typical for Mohan Rao. He's very clever, worldly, jokes and comments. So what I did here is this is a situation, I think, where me, the anthropologist, is learning from my informants. I mean, the classic social scientific method of doing research is we do our literature review and we design a project and we come up with the questions and the methods. But the anthropologists say that we should be wary of our assumptions and that we may be asking the wrong questions, and sometimes our informants will teach us things that we didn't anticipate. So while Biju and I are interviewing people at Snehavita, they're telling us about the importance of love, or sneham in Malayalam, right? Because there's also premam, and I spend some time explaining the different kinds of love, so. But many of them are mentioning this. Some of the residents at Snehavita are talking about the sort of loving care that they get from the staff there, and so they're pointing out that they're pointing out to us that love for them is an important factor. It's not an academic psychological category that one thinks to investigate, but in the ethnographic world, you should be open to being shown by your informants these other possibilities. It's somewhat like I mentioned earlier about how the Malayalam, speaking of change rather than cure, the verb maruga, taught me something, helped me make a critique that I was trying to articulate. And I have, well, at the beginning, the same critique that I made before of the person, the picture of the leg with the chain, and discussion of, well, Arawadi, critique is also discussed in the introduction. I repeat, the WHO studies, which to me is still such a key thing, and it shows us really how science is as much a social practice and about hegemonies and hierarchies as it is a rational investigation into the world out there, because the WHO studies, again, I'm reviewing the literature, since the 1960s has been following up, changing the methods, trying new angles, and always finding the same results. So it's a very robust finding, of better outcomes for schizophrenia in developing countries compared to developed countries. And I feel like when the same WHO came out with its mental health gap program, claiming a gap, I feel like that they were being scientifically inconsistent. If they have found things going better in developing countries, why aren't they finding out what's going right there and developing some intervention to help places that aren't doing as well? I just think it's not possible for certain people to believe anything but that modern allopathy and science is the right answer, despite any evidence that may indicate to the contrary. To me, it's a really a profound contradiction in the way organizations and science should be run. And this is something I've seen more and more. That something can be well studied and proposed, but the actual implementation by institutions, they can just completely ignore. An anthropologist I know who works on eating disorders in the US, and herself has struggled with eating disorders. She once recalled that, that there's a lot of social science data on eating disorders and, what are the best practices to address these issues, including social issues, not just locating the problem again in the individual, but what factors are leading people as a society to develop these things more often. And she says, all of that, none of that data affects policy. But she recalled how once when she was allowed to testify before Congress about mental health policy, and about eating disorders. She said when she told her own story, she got very emotional reactions by the members of Congress and the committee, and a promise to undertake certain changes that the data didn't compel them to take. So, I think this is also this is sort of a typical thing. I think the WHO is maybe similar. Their own data doesn't necessarily mean that they're all going to get together and just move forward just based on what the data says. They probably have, somebody probably just said, oh, poor countries don't have enough psychiatry. Yeah, and someone else said, yes, that's right. And these people are trying to solve that problem. Oh, yes, we should help them. I don't think anybody necessarily went back to their own. So that I felt was my job. In my writing, I'm trying to point out this contradiction. And that's been the purpose of my last large research project. I'm trying to learn what India does well. If they're doing better, and as I mentioned here, I hope you guys noticed that there were several developing country sites around the world that were studied, in the Philippines, and in Nigeria, India, Colombia. Among all those sites, India had actually the best outcome results. So it wasn't just a developing country, it was the place specifically with the best results. I should add, a complication in the science is that the WHO studies in India were done in Chennai and Chandigarh. So we can also say that we only really know that outcomes are good in Chennai and Chandigarh. We can assume that it's a representative of India, but there's no guarantee of that.
So do they give a rationale for choosing those particular states?
I'm sure there is a rationale, but I don't know what it is, or if I've read it, I've forgotten what it is. By the way, the best book, the best source to have a general overall knowledge of these studies, I cite it here, a Hopper et al. 2007, I believe that's the one. Let me just go now to that one. That's sort of the most comprehensive overview, edited volume. The reports from all the different centers. So there's lots of chapters from the different centers. You have a chapter from the Chennai Center, one Dr. Tata, who works in an organization called SCARF in Chennai, and some of her co-researchers were key members of the WHO studies team.
When this ISOS study was done, very early, quite long back, so the northern South Korea.
Yeah.
So when they got these results, did they do anything in the US or there in the West about implementing these findings that they found in developing countries? And did it produce any?
No, I don't think, no. I don't believe so. And I think and then they did these follow-up studies. There's the determinant of outcomes of severe mental disorders, and I think they kept doing the follow-ups because they just believed there must be some error, and so we'll adjust the methods and we'll do a follow-up. And they kept trying to find the opposite answer, and so they weren't going to sit with a result. That's why they kept moving forward, is my interpretation. Let's speak more specifically about it. I mentioned, there are a couple informants in this article that talk about their own family support, which I think is actually remarkable. Page up, let's see. Yeah, I got to go back to. Okay, there's Biju and Satish in our interviews. Sorry?
Sridevi also.
Oh, yeah, right, yeah, and Sridevi is there, yeah.
So the Satish case that
Hmm.
you mentioned,
Yeah.
where during the process of the interview they asked him who's the most daring person taking care of him. He mentions his family members, everyone,
Yeah.
who takes money the most.
Mm.
Then, in India, the spouse, especially the wife, it is expected of her to provide that service or duty or
Right.
towards the husband. So she might be doing it in a sense of responsibility
Mhm.
that she may have that love or sneha.
Right. Or it may not be loving care. So there actually is an idea of, snehem as sort of lubricated affection that I mentioned so the social relations aren't just sort of a generic concept, that there can be something I call loving social relations. So you could sort of have also obligatory, social relations that might not give the same kind of, quality of care as loving relations. And what I think is really remarkable with Satish is when he's talking about his mother and father, take him to the hospital, his wife, and then, and then he adds on, my sister and mother and elder brother are looking after me as well. I mean, that's a remarkable care network that you really don't see in the West. I mean, it's partly because extended families, live together. And, you might have, a mother or a son, or one particular, or you can have a person living alone and virtually abandoned, like you saw in some of the cases in Neely Meyer's work. So, I mean, this is just one micro example, but I feel like this is replicated many, many times over, and I think it's a big factor in helping recovery. But of course, to some degree, I'm, maybe romanticizing the Indian family. Some people point out that, that's where the problem can come from too. It's not necessarily. And I cite the work of Morrow and Lerman in this. They have an article on how, I'll just go to the citation. This became a difficult issue to contend with, the zone of abandonment and cultural geography on the street in the US, inside the family in India, sort of pointing out how you can be kind of abandoned in the family and abandoned on the street. Now, in the end, I'm kind of making an awkward argument that I still think has some validity. So the person with severe mental illness may live with their family, but they're pointing out that person may be mistreated or looked down upon, or let's say, you have some son who has the severe mental illness and they're staying with your family, but another family comes to visit about possible marriage alliance with your daughter. You keep him in his room and you don't let him, it's not, he's treated differently. And, definitely this is not, again, a happy picture. But my argument would be that it's better than living on the streets. That these are sort of choosing between two negative situations and one being less negative than the other. That even if there is sort of a lower status or even some shame, there is still support that's there. So, but again, it's this complex argument of that things aren't simply good necessarily, but they might be less problematic in this situation.
Another example I talked about a complicated joint family setup
Yeah.
in Sridevi's case, where the in-laws were not supportive.
Yeah.
That kind of, where the husband came, like there was a change in the husband's attitude towards her. So I think in the joint family setup, where in one case we see how they are being very supportive, including the elder brother's wife also being part of the family, which
Right.
Satish mentioned.
Yes.
In Sridevi's case, it's the opposite, where the in-laws are not very supportive.
Right, exactly. The family can be a good example of how the family can be a problem, but that the problem can be improved by a family action, And I would suggest one of the outcomes of this is, really to help people with severe mental health problems, it may be more important to resolve family problems than to give them the right medication. Because all of the people I saw, whether they were doing well or poorly, they're all on the same meds. What seemed to be the factors that whether someone was doing better than others was the family situation and their work situation. And then there may be other possibilities. But what also about Snehavida? I say a few words about this place, Snehavida, and I contrast it to a famous example in anthropology of a place that happens to be called Vida, almost the same name, in Brazil. A terrific ethnography, actually, called by João Biel, called Vida, Life in a Zone of Social Abandonment, that I recommend. I mean, it's a powerful ethnography, and part of my critique, maybe it's clear from my article, is that while it's very powerful and gives us important insights about care and abandonment and these things, it's based on one person. You know, in-depth analysis of Katerina, this person who's kind of like dumped into a so-called rehabilitation center and just left there. And but you get to know her family. I mean, it's really well done ethnography, but my point is that too many anthropologists are deciding too many things based on this one case. And at Snehavida, there's a bunch of different people with a bunch of different stories, and some are like Katrina from Vida, and some are much more positive.
Sir, what is meant by spirit of Foucauldian you mentioned about spirit of Foucault? Can you please elaborate about it?
What was that?
Spirit of Foucault. Foucault, you mentioned
Yeah.
spirit of Foucauldian. There is theory of, so there are two important theory you have mentioned in this. One is spirit of Foucauldian. I just need an explanation about it because you just mentioned in this.
I'm not quite, spirit of Foucauldian?
So Foucauldian theory has said it's
Yeah, okay,
Towards the end,
right. Because I think maybe it was about the biopolitics. For some reason I can't scroll all the way up.
You mentioned that you want Dr. Satya Singh, Danilo and Rose critique of
Okay, too Foucauldian. It's like I'm thinking, what did I say? Oh, I see. Yeah. Okay. Right. Okay. Well, I'm bringing up the point I brought up earlier about Foucault. What I'm saying is that I'm trying to look at the more positive effects. I'm criticizing anthropology for just kind of looking at the suffering, distraught, abandoned person, and that there's more positive. But I'm acknowledging here that Foucault shows us that what may be positive, in quotes, can also have its own forms of control. I'm kind of, I'm acknowledging that there's that, but I'm also, in a way, ignoring it to sort of say that, I recognize that such positive stories are not meant to be like, without problems and without forms of coercion and restriction. But that there is something, more, there's something good. In fact, and that's why I cite Joel Robbins, who writes about the anthropology of the good. If you're trying to point out something positive in anthropology, and I think some other social science and humanities areas nowadays, the job of academics is to cynically explain why it really is not anything worth pointing out, and anything, or what are the contradictions and problems that it brings with. So, I'm acknowledging that those are there, but I think that part of the idea of the anthropology of the good is to try to point out what is positive and actually, take it away as positive, not to simply reduce it to some cynical explanation. So I don't know if that hopefully that clarifies. I'm just acknowledging that, and there's a lot of theory. I'm speaking the language of contemporary theory in medical anthropology in my literature review, and it might not always be obvious.
Then you also mentioned Agamben's theory of sovereignty and power. Agamben means by...
Oh, Agamben, yeah. Does anybody know Agamben?
Yeah, about the bad life and because there is a
Yeah, then, well, the other kind of life is, yeah, bios, right. And so just for the sake of time, I'm not going to try to say anything about Agamben because it's a big topic in itself, but I'll just mention, I mean, he's cited in this article, but Homo Sacer was very influential, but basically I'll just say that he's an Italian philosopher and his theories of power are very trendy in social sciences and have been for quite a while. And that's part of what I'm critically engaging with. It's you know, so just if you want to know more, look at Agamben, read Homo Sacer. Some of it can be very difficult to read. The third part of it is easier than other parts of it. But Snehavita, you know, Snehavita was a really interesting place to work. You know, love is in the name. Okay, for those of you who don't know Malayalam, it kind of translates as house of love. You know, as Mohan Rao also said, but that sounds like a brothel. So, you know, there's no good way to translate, you know, house of love from Malayalam into English without conjuring up meanings you don't want to conjure up. So, but that's the name, you know, and that was an explicit thing that came up, you know, the role of love. And I also mentioned Ayurveda, you know, that Ayurveda was actually used, and I spoke to some of the Ayurvedic doctors who would visit patients at Snehavita, and I actually asked them about this concept of sneham, because it's a concept in Ayurveda too. It's not just love, it's oily unctuousness of the body, you know. So just to, maybe before we pause for our break, can anybody explain or just maybe articulate what you thought I was trying to say about the Ayurvedic idea of sneham?
I think love is an important psychic healing. That is the argument. Love is an important psychic healing.
Important psychic healing, yeah, exactly. How does the Ayurvedic concept of sneham come in, you know? I mean, my claim is largely speculative. It's something I can't claim to have proven.
I don't know, conceptually I don't remember exactly, but I think you connected with the therapies of Snehapana,
Yeah,
Virechanam, Vasti, and all of those purgatory treatments.
Right.
Panchakarma.
Right. The oleation, you know, the lubricant treatments of Ayurveda.
And how this ghee is one process when they will ask to drink.
Oh yeah.
It will remove the impurity from this body. Similarly, this sneham also will help them to survive.
Right.
To be more to cure actually, both in ways it's curing.
Okay, right, exactly. And one of the Ayurvedic doctors, I quote her, she suggests that sneham is a lubricated affection. You know, that it's, so, you know, so there may be sort of something like a biosocial theory, you know, from the indigenous concepts about what sneham is, but not something that's so clear that people could consciously articulate it. And then that's also the work of anthropologists. Somebody could research more and you know, sort of explore whether there's some idea of sneham as some physical lubrication of the body might have some connection to the concepts of love.
I thought this is a good example where conventional biomedicine and Ayurveda are in, they give opposite perspectives.
Okay.
As a medical student, I remember that all fats were bad.
Oh, okay.
So eating fats were bad
Right.
everywhere. And it was the later, after my post-graduation perhaps, when the biomedicine started explaining that fats are essential in the structure and function of cell wall
Yeah.
or in the brain and joint. Otherwise they were just restricted to joint fluids. But science also changes and
Yeah.
that is not noticed when we form our bias.
Right. So, yeah, science changes, which complicates a lot of things. Yeah, exactly. Changing views of fat. Changing debates about coconut oil fat in Kerala, by the way, right? That's been an ongoing debate, I think, which there's still no clear consensus about its effects.